Yes. Okay. Hello, everyone. Welcome back. This is day 2 of Dementia Neurology webinar. Our next speaker is Dr. Marcin Kopka. Dr. Kopka has completed his MD in Military Medical Academy in Poland in 2000 and PhD from Military Institute of Aviation Medicine in Warsaw, Poland in 2012. He's working as a neurologist and sub-investigator in Medical Center Neuroprotect. His research interest includes migraine, epilepsy, and Alzheimer's disease. The title of his speak today is A Perspective in Treatment of Alzheimer's Disease. Okay, hello, Dr. Marcin Kopka. Okay, you share your own screen. Okay, and you are on mute.
Okay.
Thank you.
So once more welcome from the Warsaw, the capital city of Poland. I would like to thank you for all the people and for me to participate in this webinar. And today I want to share with you about perspectives in treatment of the Alzheimer's disease. As we know, the Alzheimer's disease is a progressive neurodegenerative disease that produces gradual decline in cognitive function and ability to perform activities in daily living. This disease is most frequent in people before 65 years old. About 30% of the people have Alzheimer's disease, and after 65, there is more than half people with this condition. The histopathological hallmarks of Alzheimer's disease are amyloid plaques. There are extracellular deposits containing mainly with aggravated amyloid beta and neurophyllide tangles. They're intracellular localized and consist mainly with hypophosphorylated tau, a protein. So the diagnosis of Alzheimer's disease remains today on clinical grounds, and the first criteria was established in 1984, and this was quite successful and have been used for many years in clinical research. But I was shown in the analysis published in 2012, the sensitivity of this criteria was ranged from 70 to 87%, and the specificity from 34 to 70%. So it's not as much as it should be. So this criteria was modified in 2011, but remains only on clinical grounds. They include the information about various stages of Alzheimer's disease and about biomarkers, but they are not used in clinical practice. In pharmacological treatment of Alzheimer's disease, we have horizontal inhibitors. The first one was introduced in 1996. It was donepezil, and 1998 rivastigmine, and 2001 galantamine. And these inhibitors protect to disrupt the acetylcholine, the important neurotransmitter in Alzheimer's disease. We also have an NMDA antagonist, like memantine. It was the last drug approved in Alzheimer's therapy. However, the available pharmacological treatments offer mild symptomatic benefit. However, it's most important, no impact on the course of the disease. Why? Maybe because we still don't know as much as we should about pathophysiology of Alzheimer's disease. The most popular hypothesis was amyloid hypothesis. It was formulated in 1992, and according to it, the deposition of amyloid beta is the causative agent of Alzheimer's pathology and prolongs to next changes like neurophyllide tangles, cell loss, vascular damage, and dementia. The amyloid hypothesis is most spiritual framework, is most widely used in clinical drug development. but it's not the only one. But we know the Alzheimer's disease is a progression of Alzheimer's from preclinical stages when there is no symptoms to symptoms when they interfere with activity living. So the progression from the brain changes, which is unnoticeable for affected person, to causes problem with disability is called Alzheimer's disease continuum. We know that Alzheimer's disease is tough to begin about 20 years before the first symptoms appears. In 2010, it was published a hypothetical framework of Alzheimer's biomarkers. According to the framework, in the first we can detect for the first time amyloid beta in cerebral fluid, and then in the PET imaging, and then the tau also in cerebral fluid, and MRI exam, and in the end the symptoms of Alzheimer's disease appears, firstly in people with high risk of this condition, and we also with people with low risk. In 2018, it was proposed a ATN research framework. It consists of biomarkers, which are grouped in 3 groups: A for aggravated amyloid, tau, T for tau, and N for neurodegeneration. So we can detect the amyloid in cerebral fluid or in PET imaging. Also, we can picture the in PET exam a tau protein, and also we have data from MRI exam. So when people hasn't any of these biomarkers, it's a normal situation. But when someone has an amyloid beta in his, so we can assume it has a risk of Alzheimer's pathology and Alzheimer's disease. And when these people doesn't have an amyloid, probably not AD pathologic changes are more probably. In this month, an international working group published his recommendation about clinical diagnosis of Alzheimer's disease, and they recommend that Alzheimer's disease can be restricted to people who have positive biomarkers, but with specific Alzheimer's disease phenotypes, so with the clinical picture. So where the biomarker positive cognitive impaired individuals should be considered only at risk for progression of Alzheimer's disease. So it's stressed out that biomarkers of Alzheimer's disease increase the risk of developing this condition, but it can't prove it. So we can use it alone to establish the diagnosis. In natural history of Alzheimer's disease, there's this gradual decrease of cognitive function in time. When we used earlier mentioned symptomatic therapy, we can also prolong this period, but the shape of the curve of changes is similar. But when we know that people have biomarkers of the disease and we induce that treatment before the symptoms appear, we may have chances to change the progression of the disease. So it's a framework of disease-modifying therapy. From 2002 to 2014 in drug placebo difference, there is no drug. 99% of drugs tested in this period was negative, and only 1 drug was approved for FDA, so for Food and Drug Administration in the United States. And the last drug approved was memantine in 2003. Why does it happen? The reasons for failure of clinical trials may be divided to the drug-related issues or trial-related issues. in drug-related, there maybe it's a lack of efficacy of the agent, or inappropriately low dosing of this agent. The maybe higher dose may be more appropriate. Also, the excessive toxicity of lack of tolerability of some drugs can lead to high discontinuation rates of even early termination of the trials. In a trial-related perspective, the lag decline in placebo group was maybe will be the reason, because we compare the effects of the drug to effects of the placebo. So when we know so much progression in placebo group, so the drug effect may be not be proven. Also, people was earlier recruited to Alzheimer's with not definitive and confirmed pathological changes in their PET exams. There is also extensive measurement variability. There are a lot of psychological scales used to prove this condition. Also, we have a lack of measurable effect of active comparator drugs. We haven't this at the moment. In today's presentation, I would like to concentrate on the one drug which has more chances to be approved in the future. In 2016, the PRIME studies the results of PRIME study was published. In this study, ADUCANUMAB was administered in people with Alzheimer's disease symptoms and also with confirmed Alzheimer's pathology, but confirmed in PET exam. And in this treatment, the ADUCANUMAB decrease the load of the amyloid, less colorful pictures on the right in some of the doses. This effect was dose dependent and most pronounced in the higher dose. The cognitive result of the study provides support for the clinical hypothesis the reduction of the brain amyloid beta may confers to the clinical benefit. So the results of the PRIME study was encouraging, and the next trials, when emerged and ENGAGE study was performed, there was a multi-center, global, randomized, double-blind and placebo-controlled studies. The study population consists more than 3,000 patients with mild cognitive impairment or mild Alzheimer's disease with confirmed amyloid beta and PET exam. The study duration was 17.8 weeks, and the dose of ADUCANUMAB was 2 doses based on genetic phenotyping for APOE4 status. And the key points was slow progression, slow progression of cognitive decline, primarily in clinical dementia rating scale. But the studies was unfortunately and disappointingly terminated in March 2019 because the results of the interferometric futility data cutoff with 26th of December wasn't shown the clinical benefit for the patients. But the sponsor of this study performed more analysis and collects more data after the time of cutoff, and shown that in EMERGE study in people ADUCANUMAB with people who take the higher doses at 10 milligrams showed a slower progression in cognitive function measured in clinical dementia rating scale. So the result was statistically significant compared to lower doses or placebo. But the data from another of our ENGAGE study wasn't confirmed this one. So in conclusions, before the two studies was a little disappointment, a problem for the FDA, how to deal with it, or with one trial which is positive or one negative trial. So in opinion of the FDA, the areas for future investigation might include the influence of study participants with rapid disease progression. In some people, the clinical picture is more rapid than in others. We still don't know all the risk factors for it. There is also influence of dosing. I was shown the clinical benefit was proved in one study only in higher doses of this drug. And also there is also influence of ARIA management. So the ARIA is called the amyloid-related imaging abnormalities. That appears in the people treated with these drugs, the antibodies, but also in people who hasn't treatment with this drug and have Alzheimer's disease. And the amyloid-related imaging abnormalities was divided in ARIA E, stands for edema. This is some edema on the left side of the slide, and hemosiderin deposition, so ARIA H on the right in this right occipital lobe. The pathophysiological mechanism of these changes remain to be elucidated, but the presence of apoapoplectin epsilon 4R was found to be significant risk factor. So the work on ADUCANUMAB is progressing, and now the EMBARK study is ongoing, and it is an international study with almost 300 locations worldwide. It's a phase 3 study. The estimated enrollment is 2,004 participants, and time frame for the study is to 118 weeks. And estimation study completion date is in October 2023. And our centers is one of the in which the study is performed. So the FDA prolongs the decision about to approve or disapprove the ADUCANUMAB to the 7th of June of 2021. The decision was scheduled to be made in March, but was prolonged to the June because FDA wants to analyze also the data from ongoing EMBARK study and decided to approve this drug. When it happens, it will be the first disease-modifying therapy for Alzheimer's disease, a great leap for the drug development in this devastating condition. We must also remember that we have many of risk factors for Alzheimer's disease. We can divide it to non-modifiable and modifiable. We can't do anything with not modifiable risk factors like gender, the female is most pronounced. With advancing age, which is an important risk factor, about 85 years old, there is also about 30 people with Alzheimer's disease. Family history also is important, and I was mentioned about epsilon 4. When some person is homozygous from this epsilon, the chances of is 3 times greater, and in heterozygotes there is 18 times more. But I was to stress out once more that only is a genetic predisposition for this condition, and this it's maybe in clinical practice it's a situation when people has epsilon 4 but hasn't developed it in Alzheimer's disease in his life. But also we have a modifiable risk factors. It's similar to the stroke or heart disease, like hypertension, diabetes, smoking, poor diet, low education, or no physical inactivity. In 2019, it was published a SprintMind study. The aim of the study was to evaluate the effect of intensive blood pressure control of the risk of dementia. The people, the more than 9,000 people was divided in the group which was treated to the goal of systolic blood pressure below 120 milliliter of mercury. It was an intensive treatment group, and in standard treatment group, where the target for systolic blood pressure was below 140. This study was negative because the composite endpoint, primary endpoint was mild cognitive impairment or progressive dementia. But in the subgroup of mild cognitive impairment, it was shown that in intensive treatment group, there is a lower percentage of people who developed mild cognitive impairment, previous healthy people, than in people who was treated in the standard treatment. So maybe it's that we can use our treatment in so early phases, we have a greater chances to tackle this disease. It was confirmed in the Lancet report, which published in 2020, and it was estimated that about 40% of cases of dementia could be preventable with modified risk factors. So in some parts of our lives, in midlife, in later life, there is modifiable risk factors, which I mentioned before, about traumatic brain injury, hypertension, depression, or even air pollution or diabetes. And it estimated when we changes the risk factors, treat these risk factors, we can decrease the risk of dementia. So it's a place for improvement. According to many experts in Alzheimer's field, there is no one magic bullet of a drug able to treat all the symptoms of Alzheimer's disease, but maybe are in other chronic conditions like hypertension or diabetes, there is need for combination therapy. It will be a drug and drug interaction, combination therapy of the drug therapy with lifestyle management. In conclusions, there is currently no cure for Alzheimer's disease, but there is hope we change in the future. So I wish all the patients with Alzheimer's disease, their families, and the doctors that in the future, in one day, will be able to stop Alzheimer's before it starts. Thank you for your attention.
Thank you, Dr. Kopka. Okay, there is a red button that says stop sharing. We can still see your screen.
Oh, okay.
Yes. Okay, good. Thank you so much. So if anyone has any questions from Dr. Kopka and his lecture.
Any question for Dr. Marcin?
Okay, so if there isn't any questions, we move on to our next